joining today's virtual education program with Cancer Support Community Los Angeles. I'm Larissa Montalvo, and I'm the program manager here at CSCLA. And today we are very excited to be hosting a special Myeloproliferative Neoplasms awareness event in honor of MPN Blood Cancer Awareness Month. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch past webinars, please visit our website at www.cancersupportla.org. So without further ado, I would like to welcome today's speaker who will be providing an overview of MPN assessment and treatment, MPD and MPN overlap syndrome, and COVID-19 precautions and vaccination strategies for patients with MPD. Dr. Noah Merin is a hematologist-oncologist at Cedars-Sinai Blood and Marrow Transplantation Program. He is an allergenic stem cell transplant physician with research interests in clinical transplant protocols to improve the safety of the procedure, improve donor selection, and enhance graft versus malignancy effects. His clinical practice includes patients with myeloproliferative neoplasms, MPD to AML leukemic transformation, and allergenic stem cell transplantation for primary myelofibrosis and post-MPD AML. He trained at UC Davis and USC, and he's an assistant professor at Cedars-Sinai Medical Center. Welcome, Dr. Merin. We are so excited to be hosting you today.
Thank you.
You're
I'm happy
welcome.
to be here. Thanks for
Lord,
inviting me.
welcome.
All right, I'm going to get my slides up. Okay, we good?
Looks great.
Okay. So this is the second talk I've done for the Cancer Support Community Network. I did a talk in person a couple of years ago in the Santa Monica Westwood campus. And I really like doing this. So, a lot of my job as a physician is to take medical information and put it into a format that patients can understand, relate to their own symptoms, their own diagnosis, and then use that to make decisions. So I'm going to try to do that for today's talk. We know a lot more about myeloproliferative disorders in 2021 than we did just a few years ago. So I'm going to focus on some of the new diagnostic tools and how we do risk assessment. That is how we determine what sorts of treatments are appropriate for patients with different types of myeloproliferative disorders who have different risk of progression to leukemia or different risk of complications from the disease. So there's three types of myeloproliferative disorder: polycythemia, essential thrombocytosis, and myelofibrosis. So I'm going to try to talk about the similarities and differences between those different diagnoses. Then there are overlap syndromes where they have features of myelodysplasia, so myeloproliferative disorder / MPN overlap, MDS overlap, excuse me. And I'm a researcher on a clinical trial that's looking at effectiveness of vaccines in patients with hematologic malignancies. And so I'm just going to free talk about some of those issues. And then I'm going to save some time at the end for questions and answers. So please feel free to interact once I'm done with the slideshow. This is me. I already got a nice introduction from Larissa. Thank you. So the first part of the talk is just very simple definitions. I'm kind of scaling this for people who are just hearing about this for the first time. And then after the first part of the talk, I'm going to go into molecular diagnosis and treatments. So myeloproliferative neoplasms, they used to be called myeloproliferative disorders. They are now included as types of cancer that are treated. They are clonal, which means it's one cell that eventually divides and fills up the bone marrow inappropriately. Polycythemia vera refers to having overabundant production of red blood cells because of a clonal disorder in the lineage that leads to the production of red blood cells. Essential thrombocytosis is the same thing, but the offending clone is a megakaryocyte precursor. So it gives rise to excessive numbers of platelets. And then myelofibrosis is an entity that doesn't produce blood, produces like a fibrotic scar tissue that is not effectively making anything, but it suppresses bone marrow production because it prevents the normal bone marrow from functioning. So typical referrals to get worked up for myeloproliferative disorders are patients with high red blood cell count, high platelets, or unexplained low blood cell counts. So polycythemia patients present with high hemoglobin levels. Essential thrombocytosis patients present with very high platelet levels, up to 1 million or more. And myelofibrosis presents with symptoms of low blood counts and what we call constitutional symptoms like fatigue, night sweats. So the first part of meeting a new patient with a myeloproliferative disorder is the history and physical. Find out their symptom burden, how they're doing, how it's affecting their quality of life. And then do a physical exam, pay attention to the size of the spleen and other potential sites of extramedullary hematopoiesis. That is, because the bone marrow isn't functioning well, you can have some escape of hematopoietic cells and start producing blood where it's not supposed to be produced. That can be in the spleen, lymph nodes, or outside the immune system entirely. We do a bone marrow biopsy to look into the factory that produces the red cells and white cells and see what's going on. We're also looking to exclude other diseases. So different types of leukemia or myelodysplasia. And then, the field has really embraced multi-panel next generation sequencing gene mutation testing. I'm going to spend some time talking about what that means. And then we can look for patients that where there's discrepancies where the bone marrow doesn't look like a myeloproliferative disorder, or we don't find any mutations that are typical. Then we can look for other causes that are not clonal, that cause high red cells or high platelets. And so we test for erythropoietin levels, and we do coagulation testing. Here's an example of an algorithm to screen patients with polycythemia. So if you do a mutation test for JAK2 mutation, which is very common, and you check erythropoietin, if they have the presence of the mutation and they do not have a high hormone that drives red blood cell production, then it's very likely they have polycythemia. The only unlikely situation is if they don't have the mutation and they have a high EPO level. So erythropoietin can be produced for other reasons, because of a lung problem or a heart problem. We call that secondary polycythemia. It is not treated like polycythemia vera. We work up for secondary cause. So your doctor might hand you a questionnaire and get you to score your symptoms. This is used very commonly on clinical trials. In fact, Ruxolitinib was approved. It got its label mostly based on symptom reduction. So in order to tell if a drug is working, you have to repeatedly ask the same questions and get patients to score it so that you can tell whether your interventions are helping. So this is a symptom questionnaire for myeloproliferative disorders, myeloproliferative neoplasms. Patients are asked to rate their fatigue on a scale of 1 to 10, early satiety, which is really a measure of how much the spleen is taking up space in the abdomen and pushing on the stomach, abdominal discomfort, problems with concentration, night sweats, and then itching, bone pain, unexplained weight loss, and fevers. So we used to just make the diagnosis and then follow patients clinically for many years, do repeated bone marrow biopsies, and use that to change the treatments as time progressed. At this point, we kind of have a pretty good idea of what's going to happen from the time of diagnosis, because in addition to the main mutation, we can look for other mutations that significantly affect prognosis. And so if a person comes into the clinic, we do this bone marrow biopsy, we send a myeloid mutation next generation sequencing panel, we can tell what their fate is going to be, what their trajectory is going to be, whether they're likely to progress quickly or whether they're going to have decades of low-level disease that doesn't require very much intervention. That's because these other mutations, ASXL1, SRSF2, IDH1, IDH2, and RUNX1, they tend to make the polycythemia progress more quickly, turn into leukemia more quickly, or burn out and become fibrotic more quickly and not respond as well to treatment. And so that information is useful because we could tell sort of the future from the time that we see the patient the first time. And we can use that to discuss treatments such as allergenic stem cell transplantation. So we have this. So we have this information for essential thrombocytemia. So this is comparison between calreticulin-driven essential thrombocytemia versus JAK2 mutated ET. Calreticulin ET is better. P53, which is present in a lot of different kinds of cancer, is worse and is associated with progressing to leukemia. And then there's a grab bag of additional mutations that have adverse effects that are present in small percentages of patients with essential thrombocytosis. So genes that involve RNA splicing are listed down in the third line there. We have the same thing for primary myelofibrosis. Its prognosis is altered based on whether there's JAK2, MPL mutation, calreticulin mutation, triple negative, which is we don't find any of the known mutations, but it's clearly myelofibrosis, and then mutations that we see in other myeloid malignancies, ASXL1, EZH2, and RAS mutations. The list of bad mutations in myelofibrosis is pretty long. It's a type of myeloproliferative disorder that tends to have quicker progression and that we often try to do allogeneic stem cell transplant. So IDH1, SRSF2, combinations between different mutations, and then additional splicing factor mutations. Okay, back to the simple stuff. So what the clinical way to make an assessment about risk status is very simple for polycythemia. So risk status means what's the chance that the person is going to have a blood clot as a consequence of having polycythemia? And you use that to decide the treatment at the outset. It only has two factors. So if you're younger than 60 and you've never had a blood clot, then all you need is aspirin and phlebotomy to keep your hematocrit less than 45%. That means keeping your hemoglobin less than about 16.5 grams. So patients who do not have any bad mutations will just get this treatment, often for decades. Just stay on an aspirin and have phlebotomy every 2 to 4 weeks to keep their hemoglobin below 45, keep their hematocrit below 45%. If you're older than 60 or you've ever had a blood clot, then in addition to aspirin and phlebotomy, you also get hydroxyurea. Hydroxyurea is like a light chemo. We can use up to 1 gram twice a day. It just suppresses bone marrow production across the board. And so it tends to reduce the production of red blood cells. So it allows people to go further between their phlebotomy sessions, and it decreases their chance of having a blood clot as a consequence of having too much hemoglobin. We can add Ruxolitinib, which is a JAK2 inhibitor, if patients fail to fully respond to phlebotomy and hydroxyurea for high-risk polycythemia. Fully respond means that they still need frequent phlebotomies despite being on full-dose hydroxyurea. And then we can add a third drug called Ruxolitinib, which I'll talk about more later. For essential thrombocytemia, we do a risk status assessment. Again, it's based on your chance of having a blood clot, like a heart attack or a stroke. So very low risk is age less than 60, without a JAK mutation, no prior thrombosis, just need aspirin. Aspirin interferes with platelet aggregation, platelet activation, so it reduces your chance of having a blood clot. Low risk, less than 60, with a JAK mutation, but never having had a blood clot, again, just aspirin. Intermediate risk, if you're older than 60, no JAK mutation and no blood clot, still just aspirin. And if you have high risk, then which is older than 60, JAK2, we do aspirin plus hydroxyurea. And occasionally we do off-label Ruxolitinib for high risk essential thrombocytemia where you've had a blood clot in the past. So anybody who's had a blood clot or is older than 60, we treat with aspirin and hydroxyurea. Primary myelofibrosis is the most complicated one to stage and do risk stratification. So we diagnose it by looking in the bone marrow. We see too many megakaryocytes, too many of the cells that produce platelets. We rule out other things that can cause high numbers of megakaryocytes. Rule out chronic myeloid leukemia. We rule out the other myeloproliferative disorders, myelodysplastic syndrome. And then we look for mutations in JAK2, calreticulin, and MPL. And patients generally have to be anemic, have an increased white blood cell count, an enlarged spleen, and a high LDH, indicating high amount of cell turnover or ineffective hematopoiesis. So the risk stratification for primary myelofibrosis is based on this prognostic model called karyotype enhanced IPSS, or MIPSS 70 version 2. So you determine whether these prognostic variables are present, and then you add up all the points and use the points to stratify patients in a low, intermediate, high, or very high risk. So this is a nice model because it takes into account high-risk mutations, so things that we find in the myeloid panel. Karyotype is the appearance of this chromosomes under the microscope, and then presence of constitutional symptoms in circulating leukemia cells. Okay. So let's see. It's 2:23. About 20 more minutes. So I'll go to the rest of the. I'll go to the supportive care and then the science part of the talk. So the mainstay of our treatment for myeloproliferative disorders for most patients is to improve their quality of life through supportive care. And so the way you do that is you figure out, well, what is affecting your quality of life? What are the things that you'd like to be able to do that you're not able to do because of your disease? So if you are anemic and you are finding that you have decreased exercise tolerance and increased shortness of breath, then we offer transfusion support. If the transfusions have resulted in accumulation of extra iron, then we try to remove that iron through iron chelation. Patients that are at risk for bloodstream infections called neutropenic fever, they should be on antibiotics when their neutrophil count is less than 1,000. We keep their vaccinations up to date, including COVID-19 vaccinations, and we judiciously use hematopoietic growth factors. So erythropoietin stimulating agents, ESAs like Aranesp or darbepoetin, erythropoietin. Those are to increase red blood cells in patients who have low red blood cell counts, either from ET or myelofibrosis. We use GCSF, GM-CSF, Zarzio, Neupogen, those drugs to increase neutrophil counts in patients that are not producing enough neutrophils. And occasionally we use platelet stimulating growth factors, Nplate, in patients that have low platelet counts. Cytoreductive therapy means just reducing your white blood cell count across the board and your red cell count across the board with hydroxyurea, and then counseling reduction in secondary things that can increase your risk from your myeloproliferative disorder, like making sure that patients are not smoking, that they're maintaining good diet and exercise. There are some specific symptoms that relate to cytokines that are released by myeloproliferative neoplasms. So patients have itchiness, we treat with antihistamines. Bone pain from myelofibrosis sometimes responds to antihistamine loratadine and nonsteroidal anti-inflammatories. Patients often have headaches, and I try to figure out what's causing the headache. Is it a migraine type headache, or is it related to having red cells that are too high, and then treat that underlying cause to try to minimize headaches. So Ruxolitinib is a workhorse drug. It's also, the trade name is Jakafi. We use it for symptom management mostly in myelofibrosis and Polycythemia vera, and it's sometimes used off-label for patients with essential thrombocytosis who have inadequate symptom management with aspirin and hydroxyurea. So the main side effect of Ruxolitinib is that it can cause bleeding no matter what the platelet count is. So if patients already have low platelets, we start at 5 milligrams twice a day, make sure they don't have any GI bleeding, mucosal bleeding, and titrate up to 10 twice a day. Potentially, in some patients, need go all the way up to 20 milligrams twice a day. The other risk of Ruxolitinib, which is a JAK2 inhibitor, is that it can cause infections, neutropenia, low blood counts, and lead to the reactivation of viruses, hepatitis, shingles, and herpes encephalitis. So we counsel patients about that. We make sure their vaccines are up to date. We check quantitative immunoglobulins if we think patients have low antibody production. And if a patient gets an unexpected rare infection on Ruxolitinib, we often stop giving it. Okay, now I'm going to go over the newest scientific articles on myeloproliferative neoplasms. This is a little bit higher level than the diagnosis and treatment that I presented thus far. So we're focusing on the mutations that are often seen in myeloproliferative disorders. Now that we can test for 50 or 60 different commonly mutated genes, we're starting to see what types of mutations different types of patients have and which mutations go with each other, which mutations tend to occur together, and the significance of those mutations. So how does it affect the amount of time, how does it affect the rate at which the disease gets worse? And how does it affect the response to different types of treatments? So the takeaway from this slide is that JAK2 calreticulin chromosome 9 abnormalities are very common. And then among and then there's a long list of additional mutations that are seen recurrently, but on an individual patient level, they're rare. That's the long tail. So this slide looks at frequency of driver mutations according to the myeloproliferative neoplasm subtype. So the way to interpret this is that among patients that have JAK mutations in ET, 70% or about 70% of them only have JAK mutation. The light blue means they have one additional mutation. The darker, this blue means 2 additional mutations, and then dark blue means plus 3 or more additional mutations. So the main takeaway here is that myelofibrosis tends to have more mutations, and that's why, just putting them side by side, myelofibrosis is probably the worst type of myeloproliferative neoplasm because it tends to have more of these bad mutations and more additional mutations. So triple negative means it by definition doesn't have JAK2, calreticulin, or MPL, and so there are patients that clearly have essential thrombocytemia but don't have any detectable mutations. That's the biggest category. And then there are patients that have other driver mutations that are not these 3. Complicated but important to understand. And we can use this information to start to make these new genomic classifiers that are based on mutations that are present, not specifically what type of blood cells are being overproduced. And so this is like a flow chart where you start up at the top here, and if you have a high p53 mutation, then we call it myeloproliferative neoplasm with p53. And then we can actually say what's the proportion of patients that transform to leukemia, what's the proportion that burns out and becomes myelofibrosis, and what's the overall survival. So this p53 is a bad type of myeloproliferative neoplasm. And so these are the kind of patients that we try to identify early and start talking about what are some potential curative approaches that might be higher risk, such as having a bone marrow transplant, doing an allergenic stem cell transplant. So if you don't have a p53 mutation, we move down this circuit diagram. If you have one or more of the genetic mutations, then we say you have a chromatin or spliceosome mutation. That's better than a p53 mutation because we have better long-term survival and lower rate of transformation to acute myeloid leukemia. If you don't have one or more of those things, do you have JAK2, calreticulin, MPL? Yes, then you have that type. And then this is a breakdown of over here is, if you have a myeloproliferative neoplasm with a calreticulin mutation, this is the breakdown of what percentage of those patients have ET, what percentage have myelofibrosis. So you can see there are no PV patients that have calreticulin mutations. Most of the Polycythemia vera patients have JAK2. All right. So this is the new schema. It's more complicated, but it first looks at the mutations, uses that to come up with a genomic classification, and then it discusses the myeloproliferative neoplasm subtype. And that's useful for risk stratification and prognostication over a long period of time. This is a 25-year graph. Okay. So that's the modern way to think about myeloproliferative neoplasms. So this is data that shows outcomes over long periods of time. So the black line here is overall survival. And this is essential thrombocytemia. And so we report this as median overall survival is about 7 years, right? So that number is not useful for an individual patient because it averages everybody across all different types of risks. So, but these are some of the ways that that outcome can happen. Patients can die while they're in chronic phase, and what that means is they died of something else. These are often very, elderly patients who have other medical problems who died not because their myeloproliferative neoplasm progressed to leukemia. They can progress to myelofibrosis. You can get AML, or you can be alive and have myelofibrosis, or alive and in chronic phase. So it's a complicated graph, but the goal is to show the different possible outcomes from over time from start of diagnosis. And myelofibrosis is worse than essential thrombocytemia. So in my practice, most of the patients that we identify with primary myelofibrosis, we start working on transplant. We start working on allergenic transplant at the time of diagnosis, rather than waiting until they progress to leukemia. Okay? So I'm going to take some questions about that, I hope, during the question and answer period. So it's possible to have more than one type of myeloproliferative / myelodysplastic syndrome. These are overlap syndromes. So when we look in the bone marrow, if we see dysplasia, which means abnormalities in maturation in multiple cell lines, plus we see myeloproliferation, then we say you have a myelodysplastic syndrome / myeloproliferative neoplasm overlap. And once we got these mutation panels and we started using them on lots and lots of patients, it became clear that the patients who have overlap syndromes have mutations that belong to both types of diseases. So that explains why they have both things in the bone marrow. They have, so for example, myelodysplastic syndrome / myeloproliferative neoplasm with ring sideroblasts, they tend to have SF3B1 mutations, 93% of them, plus a JAK2 mutation in 57% of the cohort. So in addition to the complexity about the reorganization of the myeloproliferative neoplasms based on a genetic classification, we also have to include the fact that some of them have mutations that lead them along toward having something that resembles more than one disease. What do we do when we have, okay, so this is, the next slides are about, specifically about the molecular landscape and clonal changes in the overlap syndrome, MDS, MPN. So this is the breakdown of the different types of overlap syndromes and what they look like over time in terms of overall survival or outcomes. So this is CMML. I'm not talking about it this talk. This is like a proliferative version of MDS. It's not a myeloproliferative neoplasm. This is atypical CML-like, also not part of this talk. But this, but this is where this is the overlap syndromes. So they tend to have a better prognosis as long as they don't have a p53 mutation than atypical CML or chronic myelomonocytic leukemia. Okay. Very complicated set of overlapping diagnoses that we're starting to tease apart using these different sets of mutations. Okay. When we encounter a patient that has two diseases, we just often treat both diseases. So we have outcomes on clinical trials that are case series where patients with overlap syndromes got Ruxolitinib plus hypomethylator, which is azacitidine or decitabine, which are the typical treatments for MDS, myelodysplasia. So this is data on their outcomes over time. If a patient responds to the combined treatment, they tend to do better. And we often add, so oftentimes we'll identify a patient that has both, treat them with both, but these things generally we should take to allogeneic stem cell transplant if we can. So again, just like primary myelofibrosis with high-risk mutations, we start talking about transplant and looking for potential allogeneic stem cell transplant donors as soon as we've identified that patients have an overlap syndrome. So secondary myelofibrosis means you already had a myeloproliferative neoplasm and you've been treated for a long time, but then it acquires additional mutations. It becomes less differentiated, more fibrotic, stops producing the red cells for PV or the platelets for ET, and it just becomes fibrosis. So that's a form of progression of a previous myeloproliferative neoplasm. We call that secondary myelofibrosis. Also a bad sign, also something where we should be starting to think about allogeneic transplant if the patient is able to do it. Just to mention on the history, it's a pioneers in hematology defined these syndromes, and they understood that they were relating. The ET could progress to PV, and both of them could turn into myelofibrosis, that they're characterized by blood clots, risk of bleeding, and risk of turning into AML. So when patients are already about to get leukemia, then we definitely add leukemia type treatments, including hypomethylators like we would use for an overlap syndrome. So if you look at a bone marrow patient who has myelofibrosis and you see that they are starting to develop blasts, they are starting to transition to AML, then you should definitely give them hypomethylators and start talking about allogeneic stem cell transplant. And the reason we do that is because once patients have progressed to AML, it's very bad prognosis. So this is data on treatment outcomes following leukemic transformation. So once you turn into leukemia, the prognosis is not good. So you kind of fall off the curve once you get leukemia, because now you have a very aggressive type of leukemia. This is old data from 2016, and things have improved somewhat in terms of overall survival, because transplant itself has gotten better and we can transplant patients sooner and find more donors. This analysis suggests that if you had a transplant, you had a better outcome than if you didn't have a transplant. So there is a push to use the mutations that are present at diagnosis to make a transplant, no transplant decision. And here are other current recommendations for how to discuss whether or not a patient should go for a curative allogeneic transplant or continue on like supportive care and cytoreductive agents and JAK inhibitors. So patients that have, so this is specifically for myelofibrosis, primary myelofibrosis, high-risk disease. If they're requiring transfusions, if they already turn into leukemia, then you should have a transplant. So those are based on the baseline characteristics. And then if you didn't have a transplant and you're following somebody, if they're starting to progress or if they acquire additional mutations, those are other reasons to bring up allogeneic stem cell transplant for that person. So how does it look if you do it? This is the most up-to-date retrospective case series. So this is for what happens if you had myeloproliferative neoplasm, you were going into a blast phase, you're starting to get evidence of leukemia, and then you went for transplant. What are the outcomes? So I'll tell you, they're not easy transplants to do, but things are getting better. Part of the problem is that because there might be underlying myelofibrosis, it's hard to get the new stem cells to go into the bone marrow and engraft. So oftentimes, because the bone marrow itself, the niche where the hematopoietic cells from the donor are supposed to go, is damaged by the prior myelofibrosis. So they tend to take a long time to engraft, that is, and start producing new blood. And it can be a bumpy course, but you could see that even from 2001 to 9 to 2010 to 16, things have gotten better. So for patients that had their transplants between 2010 and 2016, you had 55%, 55% survival out to 48 months. And this is the relapse rate, 43%. And non-relapse mortality means people died from the transplant, not from leukemia or from myeloproliferative neoplasm. These data include the old transplants, basically the Stone Age of allogeneic transplant, 2001 to 2009. So in the modern days, the non-relapse mortality has gone way down. So your chance of dying from the transplant and not from the disease is really low now. Used to be much less safe. So 4% now versus 43% in the beginning of the century. Okay, so one of the big changes, the new thing in allogeneic transplant is now we can use half-matched donors. So that means everybody has a potential donor in their family. 95% of people have a child or a sibling, sometimes a cousin or a nephew that we can use as a donor. We're not restricted to fully matched donors anymore. Now we can use haplo-identical or half-matched donors. And so this is what the transplant outcomes look like using haploidentical donors. So what this really means is now we can do transplants for people that didn't have a donor option before. So if you have a high-risk disease or you've already started to turn into leukemia, you can get you can get better than 50% 1-year survival using a half-matched donor, which is a pretty good option. I was going to make a big slide about COVID-19, but Biden beat me to it. So I think it's very clear that everybody with hematologic malignancies should be vaccinated against COVID-19. The disease is still circulating. Additional variants are still coming into our community. And they should maintain precautions. So having said that, the immune system of a person with a myeloid malignancy is not that bad. And most patients will mount a vaccine response if they get the vaccine. There's a blanket recommendation to do a 3rd dose, and mostly for Pfizer. The only data we have right now is for Pfizer because Pfizer appears to wear off sooner than Moderna. We have no guidance about what to do for patients who got Johnson & Johnson, AstraZeneca, and Moderna.
Okay, great. Thank you so much, Dr. Merin. It looks like that's all the time we have for questions today.